Well, hello, everyone. This is Nicholas Hall, founder of Graham's Foundation. I'm here with Mikael Norman. I'm here, you can't tell because it's a Zoom recording, but I'm here in the United States in the morning, and Mikael is over in Sweden, correct?
Yeah.
Yep, over in Sweden. So he's already had all of his coffee. He's well into his day, but I appreciate everyone taking the time to listen. So, Mikael, as I say, I like to just give my guests the opportunity to introduce themselves in the way that is most relevant for you. And obviously, today we're going to be talking about research in the area of pain management for neonates. And as I shared my experience being in the NICU, I could see the pain that our babies were probably experiencing, and I felt like I was uh, feeling it for them. And so it's obviously an area that I'm terribly curious and interested to learn more about. So with that, if you might just share with our audience a little bit about your background and and certainly the research that you're doing currently and most recently, and we'll jump right in.
Okay. Hello, everyone. I'm Mikael Norman. I'm a neonatologist in Stockholm. I work at the Karolinska University Hospital, and I've been doing that for most of my work life. Um, in recent years, I've focused more and more on research. So at present, I'm a professor at the university, the Karolinska Institutet. And my main interest is present is research about very preterm infants, their problems when they're newborn, and also their outcomes in the long term. And for that purpose, we use, especially my research is focusing on using different registers in Sweden, registry data.
Excellent. I appreciate that. And many parents, we, as I've shared, that prematurity is not a diagnosis. It's an occurrence. And so, you start to parents start to look into the data of all the possible outcomes, and it can be quite overwhelming. And I remind parents that your baby it's like 0, 1. They're not, it's not 50% this outcome. It's either this particular condition has impacted them or not. So I'm curious if you could maybe just talk a little bit more about the research and how it's being conducted when you say you're using the registry. For those of us that don't have a background in research, um, sort of, just if you could maybe talk a little bit more even about the type of research that you're doing and what is it that you're perhaps hoping to glean from that
Mhm.
research, and if you glean something, how in the real kind of in the real world, how that might impact practices. And perhaps, we talked a little bit about pain management. I don't know
Mm.
if that's maybe an example that you could use.
Mhm. Yeah. Well, I think most of you know that the focus on results for especially very preterm infants has been very much on the proportion that survive after very preterm, or especially extremely preterm birth, and their what we call medical complications when they are in intensive care. They can have different complications from the lungs, from the brain, from the gut, and so on, infections. And also on the long-term outcome, it's been a focus for the last, I think, 2 or 3 decades. 25 years ago, we didn't know very much about the longer-term outcomes, but now we have some more data to rely on when we do counseling for families and parents. Another dimension that I became interested in because we had data to explore this was what about neonatal intensive care? The babies are in the intensive care unit usually for long periods of time, and they are exposed to procedures in intensive care that people know are painful. But actually, how big is the problem with pain in neonatal intensive care? It has been fairly difficult to assess. Is it a big problem? Is it a small problem? There are some research reports where people have counted on procedures, how many blood samples, how many days on mechanical ventilations, and so on, as a means of trying to sort of assess how much pain are newborn infants exposed to. But actually, there are very few reports assessing directly pain.
Hmm.
And for that purpose, we started in Sweden. Now it's more than 5 years ago. We have what we call a quality register. All neonatal units in the country report different things, procedures, outcomes for babies born, or all babies in neonatal care, actually, not only preterm, but it's dominated by preterm babies. And all units report on a daily basis nowadays. So every day, all babies in neonatal intensive care in Sweden are reported to this register. And some years ago, we decided to try to get some sense or feeling for how much pain are the babies exposed to.
Hmm.
So we started we had a very simple question in the report form. Did the infant experience pain in the last 24 hours? Yes or no? And if the answer was yes, there was a follow-up question. How was this assessed? Was it assessed by what we call the pain scale or some tool for assessing pain? Or was it just a subjective measure, like the baby had some condition in the abdomen, painful? We know it was painful because the baby cried and so on. And also, if the baby was in pain, we had a question about treatment, and especially pharmacological treatment. Was there any local anesthesia, for example, or a drug, an analgesic drug or so given? So those were the three questions that we tried to explore and tried to describe the size of the problem with neonatal pain in very preterm infants.
Now, can you when you said very early or extremely early, just so that we're all on the same page, because I know sometimes that definition, I mean, partly it's changing because babies are being saved that are of earlier, and so
Mm.
when you say very early,
Very preterm to me means more than 8 weeks before term. And extremely preterm is a baby born more than 12 weeks before term.
yeah, okay,
And in Sweden, the national guideline for intensive care for preterm babies starts at 22 weeks of
yeah,
pregnancy. And at that time, the national guideline says you may consider intensive care. It's not recommended, it's a consideration together with the parents. And from 23 weeks, we have a recommendation. So physicians in Sweden recommend initiation of starting up of neonatal intensive care of babies born at 23 weeks and upwards, so to say.
gotcha. And it's part of the reason, you mentioned 25 weeks or 25 years ago was part of the reason or interest just because more and more babies that were being born very or extremely premature were actually surviving,
Yeah.
right? So if we're able to save them, we probably owe it to all sorts of people. They're going to ask questions because there's going to be a very, we don't know what the outcomes. We've saved them. We're going to send them home,
Mhm.
but we don't know yet the impact of our care.
No, no, that's true. That was one of the reasons why we started a fairly large birth cohort. We sample every birth in 3 years, below 27 weeks at that time, and had a very, very thorough protocol too, both in the neonatal period, but also a follow-up protocol to see what was happening.
And when you share that every day, and every NICU is required to provide this the data. Roughly, how many ballpark? Like, what's the sense? What's the in the entire country? What's sort of the average census of premature babies in the neonatal intensive care units?
Do you mean how many babies each day who
Yeah,
are in intensive
yeah,
care?
roughly.
I think we have about something like between 450 up to 600 babies each day in neonatal care, something about that. Sweden is a country of 10.5 million people,
Yeah,
and there are born about 100,000 births each year. And the very preterms are about 1,000 babies, 1%. And the extremely preterm babies are about 3 to 400,
yeah,
depending a little bit how you count.
yeah. It's interesting. That's fairly similar to here in the U.S. Um, we though there's this common statistic that is thrown out that 1 in 10 babies are born prematurely, and we need to do something about that. And I have a background in numbers, but it's accounting and investments. It's not the kind of numbers that you're looking at, but numbers are numbers. And I will tell people, yes, if you look at what's considered a term baby, then yes, perhaps 1 in 10 are born technically premature. But if we're really talking about the babies that are going to require, should they survive being born premature, that they're going to require weeks or months of medical intervention, and those are the babies that are more likely to have feeding issues,
Mm.
breathing, auditory, uh,
Yes.
cognitive. That's more like what you're talking about. It's one.
Mm.
It's 1%. So it's more like 1 in 100, which in the United States that's 40 to 50,000 babies. So it's not like it doesn't matter. It's a it's
No.
it's meaningful because a lot of those babies like require extra care in the educational system. I mean, there's um, there are potential costs there, so it is critically important. Um, so with the research, and I am curious about you're asking the question was asked, did the baby experience pain? Was there underneath that, was there like and here are examples of what would likely be like, it's
Mm.
it's just such a broad it's such a
Yeah.
broad question. I would think that there'd be likely to get a lot of yeses, or maybe no's because they don't want their babies to, they don't want anybody to think that their babies are experiencing pain. I don't know. I'm really curious sort of what you have seen over time and whether or not has that question continued, and if so, have there been tweaks or modifications to it to try and get more accurate, the ability to reflect more accurately on what you found.
We thought in this way that the more precise you try to define pain, In a way, the more difficult it becomes because you have to have much more information. This daily reporting is about a huge number of things. So we had to consider the workload for the reporters, usually nurses or nurse assistants doing this.
Yeah.
So we couldn't do like we don't have any we didn't have information if it was what we call procedural pain, something like a blood sample or catheter inserted through the skin, or a sort of more ongoing pain, like when you and I have a headache or something.
Yeah.
We
Or like
couldn't.
what my back's been feeling like the past couple of
Yes.
days. Yeah.
So we couldn't make a protocol for this survey, this national survey that was too detailed. And also when we started this information collection, there was many opinions what should be considered as pain or painful and so on. So in the end, I had to make a decision, and that decision was that the best people to assess if the baby had any pain the last 24 hours were the staff caring for the baby,
Right.
and also if they had documented in the medical records or the nurse records there was a documentation of pain, then the answer to the question would be a yes. If there is no documentation about pain, regardless if the baby was on mechanical ventilation or so, people were instructed to answer no.
I think it's I think that's a good point what you shared. And um, I know as someone that's been asked a million for my opinion on surveys millions of times now. How was your experience here? How was your experience there? We're asked all the time. Uh,
Yeah,
and we survey our families and their experience of our support. We don't do it very often, and we only ask a few questions.
mm,
It's like if someone can't, to your point, if you can't do it in like less than a minute, chances of you
mm,
getting accurate, truthful information, I think, just goes down precipitously because people are
yeah,
like, this is just, I don't have time
yes,
for this. So if they do finish it, they really are thinking less and less,
yes.
really to give you a really thoughtful answer.
So given that limitation, still I think we got very interesting information
Hmm.
from that study. So we assessed about, there were a few units, as I remember now, I think it was 2 or 3 smaller units that did not report on pain. On the other hand, these units did not care for the most complicated intensive care cases.
Yeah.
We had information on about 3,600 babies, and we assessed almost 200,000 days of neonatal intensive care, something like that. And one result was that a clear majority of all these babies had experienced pain. And that maybe that's not so unexpected, but still, I mean, if you would ask a child, an older child, would you go to the dentist if it was painful? Would you go to the hospital if it was painful? I guess most of the answers would no, I would never do that.
That's why people tend to avoid and not go, even though it might be helpful. But that,
Yeah, so I mean, these babies, they have no option. They are in intensive care, and
hmm.
almost 90% of them had experienced pain, which is expected, but still it's a very high number. And the pain exposure was related to how immature the baby was. So the most immature babies were those who had most days with pain. And of particular concern in our context was that those born before 26 weeks, there was a sort of stepwise increase on the load of pain. So babies born at 27, 28 weeks and up to 31 weeks, they had some pain during the first day of intensive care, but then it rapidly declined. But this was not the case for the babies below 27 weeks. So the proportion exposed to pain stepwise increased up to almost 50% for babies at 22, 23 weeks of gestational age. And it was fairly sustained over the first month of life. So that was, I think, an eye-opener I hope, for neonatal care in Sweden. I think many people thought that this was not a big problem, but actually it is. It's a big problem. Both because of the sort of suffering right there and then in the intensive care, but also there are some research connecting pain to a different development trajectory of the brain and nervous system. So it, in the long run, will be more sensitive to incoming sensations. And you know, some of children born very preterm or extremely preterm, they are more sensitive to incoming information. The sensory system is more active than the motor part, the sort of outgoing. So this was important, I think, to describe the problem, to quantify the problem. This is a big problem in neonatal intensive care still. Another thing we found, we measured how many babies are exposed to potentially painful procedures, like mechanical ventilation, catheters, blood sampling, other samplings. And that was interesting. More or less all these babies born extremely preterm had a big load of potentially painful procedures, but the proportion actually experiencing pain was much lower. So from that we learned that, for example, all days on mechanical ventilation are not painful, probably not painful. So that, I think, is also an important piece of information, that sometimes you can perform blood sampling, you can perform mechanical ventilation through a tube without causing pain. So that's optimistic information.
Yeah.
A third message that we found was when we were looking at pharmacological treatment, drug treatment of pain, those who had a heavy drug treatment like intravenous analgesics like morphine, there was a sort of inverse correlation. It was those with more mature babies had higher proportions treated with morphine for pain, whereas the most immature babies with most pain, they had the least treatment with morphine. And we think...
Why do you think? Yeah, I was kind of curious why. I can imagine maybe they can't cry, they can't, I don't know, they can't react the way that a more full-term baby can just, in its reaction, can let you know it's experiencing pain.
That could be one reason why they are sort of undertreated. That their signals of pain are more weak. But another thing we think perhaps is more important in that context is the fear for side effects. Because morphine is known to, if you pass a little bit over the line, you will cause a drop of blood pressure, hypotension, and that is very severe side effect in an extremely preterm infant, because the blood pressures are already very, very low. So if you lower them even further, there is a risk for the circulation to suffer.
Yeah. Yeah, a lot of parents I know that we will talk about that our preemies have this sort of preemie brain or preemie like sensitivity, and it's hard. It's not, yeah, it just seems to be um, something that's it's difficult to maybe always diagnose exactly, and maybe doesn't quite doesn't occur the same as maybe a, a, a full term. If a baby that was born full term and has like what we say ADHD or you
Mm,
know there's just but certainly to your point, I mean sensitivity um, to noise, to light, to um, is extremely common. It seems.
mm,
Again, I'm not doing this is anecdotal. This is just having talked to hundreds of parents like myself over the years. It seems to be
mm.
quite usual. In I guess in this at this point, are there is the results of the research, is it impacting at all care, or is it too early? Is it more that we're sort of at the awareness stage and talking about it and seeing and considering how that might impact care and how you provide care at the to the babies?
Yeah, no, no, I think it pain has been sort of a very important topic for at least 2 decades in neonatal intensive care. We try in every way we can to reduce pain and treat pain and assess pain. But as you said, it's difficult. So the most immature babies, they express pain differently, and sometimes I guess we miss it because the tools we have to assess and evaluate pain, they aren't optimal. They are also time consuming, these pain scales to assess. You have to sit by the incubator and measure different things. Perhaps in the future, AI could be a good thing to put together all the signals from the baby: heart rate variation, blood pressure, facial expressions, perhaps some EEG and so on, to get a better and quicker picture if the baby is in pain.
Yeah.
So that is for the future. But I think today we try to treat, we try to reduce, painful procedure as much as we can. Um, but it's good to have now a verification that the problem is still existing. So there's a long way to go to have it better solved.
It is pretty exciting. I know, having had spent a career um, myself in working with technology companies, it's a multi-edged sword. I don't even say a double-edged sword anymore. It's just it's exciting and scary at the same time. Sometimes, but I can imagine the possibilities of being able to improve the the ability for doctors and nurses and therapists in more real time to assess and impact and hopefully improve the care. Because
Uh,
we parents, on the one hand, we are of course grateful that more babies that are born early are surviving,
mm,
live a long life, and of course we want our babies to be able to live as healthy and normal of
mm,
a life as possible. So, and only time will tell, but I do think every 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 day in that NICU, every interaction that that they have has a potential impact. And so this research, it's inspiring to know that there's people like yourself, and I know it's happening all over the world, that are looking at this, considering it, wanting to better understand it, and hopefully that it'll impact the care and obviously as a result the outcomes of our babies. Michael, is there anything that we haven't talked about or I haven't asked up to this point that maybe if I did, it would have given you the opportunity to share something that you'd still like to share before we wrap up our conversation?
Well, thank you very much for
Thank you.
what you're saying. In the context of pain, I think when I said that the tiniest babies have the least intravenous treatment with drugs, I think it's also important to use the power of non-drug pain relief, like skin-to-skin care, even of babies in very aggressive intensive care. Skin-to-skin care carries the power to reduce both stress and pain for the baby and for the parents. So, it's an enormous power in the skin-to-skin contact. So I really believe in it, and I know it is very effective way to treat pain in preterm infants. So don't just rely on sort of drug for pain.
Yeah. No, I appreciate you reminding us of that, and to the parents, don't be afraid to advocate for skin-to-skin care, and because it does makes a difference. So, well, Michael, again, I want to thank you for taking the time to talk to me today, and
Sure.
thank you.
Thank you.